Thank you very much, sir. We'll take the questions in the end. We'll go ahead with the case presentation. I would request Dr. Archana to please share her slides and start the presentation. Archana, full screen. Your video on if possible.
I'll start, sir.
Yeah.
Good evening, everyone. My name is Dr. Archana. I am from Acute International, Chennai. So today my case is about Mrs. M, 43-year-old female who hails from Chennai, who's a homemaker by occupation and an informant being herself. Chief complaints is she's a case of renal renal transplant, came for regular OPD visit. History of presenting complaints. I would like to start my history from 2022 January, when patient was apparently normal. Until then, when she presented with history of left side arm pain for 1 week, which was insidious in onset, gradually progressive, intermittent in nature, dull aching type of pain, no aggravating or relieving factors, not associated with chest pain, palpitation, or sweating. On evaluation for the same, she was found to have a BP of 210/110 and a creatinine of 5. She could not remember about the urine test. She was told that her both kidneys had shrunken, and also the MRI scan was done to assess the blood flow, which was told to be normal. There was no history of any fetal edema, frothy urine, decreased urine output, breathing difficulty. There was no history of headache, blurring of vision, loss of consciousness. There was no history of joint pain, rashes, or excessive hair loss. There was no history of easy fatigability, blood transfusion. There was no history of fractures or bone pain. No history of over-the-counter use of painkiller medications and or any other alternative medicine use. There was no history of recurrent UTI infections. She has 2 kids, first child born at 2008 and second at 2012. Both are male, doing well. Both were born by LSCS and indication being non-progression of labor. There was no any history of BP or history of proteinuria during the delivery or during the pregnancy. And the scan done during the pregnancy were told to be normal. She was started on antihypertensive medicines. She required 2 antihypertensive medicines to control her BP, and she was also given sodium bicarbonate and other calcium supplements. Over the next 3 months, her creatinine increased to 9, and she was initiated on hemodialysis through the right IJV non-tunnel catheter in view of uremic symptoms. The dialysis was continued through right arm AV fistula and temporary catheter was removed. She was getting twice weekly dialysis with intradialytic weight gain of 0.5 to 1 kg with a residual urine output of 500 to 700 ml per day with no intradialytic complications. And she had received vaccination against hepatitis B, pneumonia, COVID, and influenza. And she was given injection to improve the hemoglobin levels, and she also was put on medicines to reduce the blood phosphorus levels. She was worked up for a live donor renal transplant with husband as being the donor. Husband age was 50 at the time with no comorbidities. Husband's blood group was B negative and the patient's blood group was B positive. During the transplant workup, she was told to have antibodies against the donors, but as the cross match was negative, they told they can proceed with the transplant. And she does not remember anything about the HLA matching. Cardiac, the urology, gynecology clearance for transplant was obtained, and few days before the date of transplant, tablet prednisolone, tacrolimus, and mycophenolate was started, and she underwent ABO-compatible live renal transplant on 22nd of August 2022. On the day of surgery, she was given an costly injection, which she mentions to be about 1 lakh. And she was told that the surgery was uneventful. And post-surgery, she was monitored in ICU. She had a good urine output, and the creatinine came to 0.8 on day 4. Tacrolimus levels were done, it was told to be normal. Another dose of the cost injection was given on day 4. The urinary catheter was removed on day 4. Drain was removed on day 5, and the patient was shifted to ward on day 5. On day 10 of post-transplant, patient developed history of fever with also raise in creatinine and also drop in urine output. It was not associated with pain at the site of with the pain at the graft site or burning micturition or any oozing from the drain site, abdominal pain, abdominal discomfort, abdominal distension, cough or breathing difficulty. USG of the transplant kidney was done. It was told to be normal. Blood flow to the kidney was told to be normal. There was no obstruction in the flow of urine. There was no collections around the graft kidney. Tacrolimus level, DAC and cultures were sent, and the patient was started on IV antibiotics. Another injection was started, which was given for 3 days. And also she underwent the biopsy of the graft kidney. Then she was told that she had to undergo a special type of dialysis, which she has to get like 3 to 5 sessions, and also she had to get a special injection called ATG. During the third dose of ATG, her BP shot up, and she had breathing difficulty, for which she was dialyzed. On day 25, the creatinine came down to 1.25, and the urine output also improved. So the discharge creatinine was 1.1, and she was discharged on day 30 with 2 antihypertensive medicines and 2 medicines as a prophylaxis for infection. During the follow-up, blood tests and urine tests were done, and occasionally tacrolimus levels also were done. 6 months post-transplant, she came with the complaints of high-grade fever with chills, burning, micturition. There was no history of decreased urine output. There was no history of pain in the graft site. For which she was admitted in ICU as the BP was low. IV antibiotics were given. Creatinine had increased to 2.3. She also received IV fluids, and the dose of immunosuppressants were reduced. USG of the graft kidney and the bladder was told to be normal. She was told that she's having infection in the blood and urine and has to take antibiotic for 14 days. After 3 days, the creatinine came down to 0.8. And gradually the need for antihypertensive medicines were reduced and was stopped. Coming to past history, there was no any significant past history. Family history, there is no any similar renal disease in the family. Personal history, she consumes mixed diet, boiled water, cooked food, normal bowel and bladder habits, no history of any alcohol, smoking or tobacco use. Menstrual history, she has a regular 28-day cycle with a moderate flow. Socioeconomic history, she lives in a Pakka house with a good ventilation, good water supply. And she belongs to upper middle class of the modified Pisani classification. Come to summary. This is a 43-year-old female, a case of renal transplant with unknown native kidney disease with a positive sensitization history, with a hemodialysis vintage of 5 months, who underwent ABO-compatible right donor renal transplant with husband being the donor, with an uneven surgical procedure, with acute graft dysfunction on POD 10, treated with plasma exchange, was 5 in number, and also 3 doses of ATG. It's probable acute rejection, AMR and TCMR, with a post-transplant period complicated with UTI, now with a normal graft function. Shall we continue the examinations?
Yeah, please. Now here at this point of time, you have to come up with a provisional diagnosis.
So,
yeah, what's your diagnosis?
So it was acute graft dysfunction, sir.
No, actually, in this situation, what you have to say is that, like, it's a ABO compatible, living related donor, kidney transplant recipient. So this is the first thing. ABO compatible, living related donor, kidney transplant, number 1. Native kidney disease, if you have something in mind, you have to say the most likely, no, when it is unknown, the probable native kidney disease that can be set. And the third thing is that here it is difficult to give just one single diagnosis because, you know, it is a kind of a listing of events. You can say that I just list out the important clinical events post-transplant. You can say that acute graft dysfunction and the anti-rejection therapy being given, then now UTI, exacerbation of hypertension and all that. That's what. So the diagnosis has to be told in such a way that whenever a kidney transplant recipient is your case in the examination, so the living related or disease donor, whatever it is, ABO compatible kidney transplant recipient. That is the first term, then the native kidney disease, and then you can list out the problems. And if there is any particular problem currently running, then you can focus on that. So that's how it has to be structured. Okay.
Yes, sir.
So what are the important events that happened post-transplant?
So post-transplant.
One is acute graft dysfunction on day 9, right?
Day 10, sir. Day 10. She had acute graft dysfunction on day 10.
Yes, infection.
Yes, sir. She had infection after 6 months. So it is ABO compatible.
Fine.
Live
So these are the only
renal
two things.
transplant. Yes. It's ABO compatible live
Okay,
renal donor transplant.
So what is the likely the native kidney disease that has culminated in ESRD in her?
So most probably I would think about IgA nephropathy, sir.
No, you have to give the differential diagnosis here.
Yes, sir. First is IgA nephropathy, sir. Then hypertensive nephrosclerosis.
Okay. In any woman, actually.
Last would be SLE.
Yeah, in any woman, always you have to think one particular disease on the back of your mind. In any renal syndrome presentation, what is that?
Lupus nephritis.
Yeah, lupus nephritis. Of course, the picture is only 2 years until 40 years is okay. 40 years is little longer for SLE to manifest, but still it has to happen. It can happen. So in your history, in one sentence, you have to say there is no evidence suggestive of lupus in the form of arthritis, mucositis, and oral ulcers. Evidence for serositis and so on. You can just put it in one sentence, suggestive of autoimmune diseases, particularly lupus. That's very important. Okay. So what are other diseases? So actually, she presented as severe hypertension, right?
Yes, sir.
But non-oliguric, right?
Non-oliguric.
She was non-oliguric. Yeah. Severe hypertension. There was, this is not a classical presentation of any glomerular disease. Usually glomerular diseases, they present with edema, then proteinuria, and hypertension and so on. But now our wisdom, the practical wisdom says that this kind of distinction of glomerular versus interstitial, just based on absence of edema, oliguria and proteinuria and all that, it's very arbitrary. It all depends, like any number of patients with IgA nephropathy or other glomerulopathies, we have come across the patient remaining non-oliguric. How do you explain this? Because, if the tubular injury is very dominant, simultaneously it is happening along with the glomerular injury, there can be non-oliguria, but hypertension can still be there. So, but in general, whenever you commit as glomerulopathy, always you have to think whether there was an edema, and history suggestive of proteinuria like frothy urine, and then hypertension and so on. Having said that, what are the interstitial diseases which present with hypertension?
Yes, sir. Reflux nephropathy, sir.
Yeah, reflux nephropathy, and then of course your ADPKD. Autosomal dominant polycystic kidney disease, like it is an interstitial disease, but yeah, ADPKD, yeah, yes. ADPKD and the hypertension, one of the classical one of the presenting phenomena, features is hypertension. But in general, it is a reflux. Okay, reflux nephropathy because of the scars which they alter the anatomy there, and there can be distortion of the blood vessels, and that can result in downstream ischemia and hyperironemia and so on. Okay, that's what is happening. Okay, among the glomerulopathies, what is the likelihood for a 40-year-old lady to develop, to present with hypertension and severe hypertension and elevated blood pressure as well as increased creatinine? What is the serum creatinine 2 years before when she presented?
5, sir. It was 5,
yeah.
sir.
So, okay. So what are the glomerular diseases possible? Of course, IgA nephropathy, I wouldn't rule out. But again, IgA nephropathy in India, particularly South Asia, the onset is little early. Okay. But still we can't rule out. SLE, there was no feature suggestive of SLE. Yes.
No features, sir. Then
yeah,
hypertensive nephrosclerosis. Hypertensive nephrosclerosis.
No, actually, hypertensive nephrosclerosis. No, for hypertensive nephrosclerosis to happen, there should be a long-standing hypertension. Is it not? She was not known as hypertensive. And again, this hypertensive, so-called hypertensive nephrosclerosis, hypertensive nephropathy, in the Indian context, it is very much questioned. It's very much questioned. Hypertension alone, just essential hypertension, the primary hypertension, as a sole cause for CKD, in the Indian context, it is a big question mark. The hypertension might have been a phenomenon, the feature of the underlying kidney disease, and particularly in a lady who was not known to be a hypertensive. Okay, that's it.
So it could be a secondary FSGS.
So I wouldn't encourage hypertensive nephrosclerosis. Yeah, FSGS, certain forms of FSGS can present late. And can it be C3GN?
Yes, sir, C3GN also.
Yeah,
But the age is a bit...
Again, in the dense deposit disease, it presents very early during adolescence and 2025, whereas C3GN can present little later. C3GN can present later. It is possible. It's very much possible. Okay. And anything else? Yeah. So these are the diseases. And one thing, the diseases which we should not miss out is the thrombotic microangiopathy, the TMA. Okay, the TMA, had it been TMA, ideally we are supposed to do kind of the genetic studies and find out so that, the recurrence, the prognostication, post-transplant recurrence, the discussion and our focus on that should not be missed out. Again, now the TMA, the so-called HUS, atypical HUS syndrome is so heterogeneous, and each category has got its own age of predilection, and many a times, the presentation is only severe hypertension and very rapid progression to ESRD and all happens. So unless you have an index of suspicion, you may miss out. And by the time the kidneys are contracted, the telltale evidence for the systemic involvement of the TMA process may not be there in terms of platelet, low platelet, and so on. So that also has to be kept in mind because, it occurs to me because, the BP is very, very high. There are very few diseases which present with such a very severe hypertension. One is IgA nephropathy. The other one is reflux nephropathy and SLE. These are the three diseases, at least in Madras Medical College experience, which have presented with papilledema. And in the past, we used to have a lot of aortoarteritis, the renovascular hypertension that also presents with that. So in a woman, rapid hypertension, rapid progression of kidney failure, the renovascular pathology also has to be thought of. So in that case, you have to palpate all the peripheral blood vessels, and the blood pressure has to be checked in all 4 limbs and so on. Okay, fine. In the obstetric history, you just mentioned there are 2 children and both LSCs, right?
LSCs.
And you are sure that there was no preeclampsia, right?
There is no preeclampsia, sir.
Preeclampsia. So what is the implication of history of preeclampsia, positive history of preeclampsia later on?
So it could be a lupus, sir. It could have been lupus nephritis, sir. And also...
yes, it increases, yeah. Yeah, always remember the preeclampsia, the story does not end over there. So it is, in many unfortunate persons, there can be a lingering injury, pathology that can cause a kind of a generalized vasculopathy and that can predispose for the hypertension and chronic kidney disease and the cardiovascular morbidity as well. So preeclampsia history is very important, and whenever there is a history of preeclampsia, it is mandatory that the lady has to be subjected for evaluation periodically, even if the BP touches now. Okay, it's always this factor. So here there was no history suggestive of that. And what is the birth weight of the second son?
I did not ask. I did not ask.
So the importance is that, many a times, during pregnancy, the apparently normal number serum creatinine, it is kind of mistaken as normal. For instance, 1 milligram creatinine during pregnancy. Okay, 1 milligram creatinine and then 140/90 blood pressure during pregnancy. It is definitely abnormal. So that sometimes it can be missed out. So what I mean to say is that there can be a subtle underlying kidney disease. If it is there, that may reflect on the birth weight and other phenomena as well. So it was normal. I mean, it was 10 years ago. So probably something has happened after that only. So now it is anybody's guess. And suppose if you do an imaging and there is no evidence for reflux, kidney is normal and contracted and the ureters are normal, can you rule out reflux nephropathy? You can't really rule out reflux nephropathy because sometimes the reflux over a period of time disappears, but the damage that happens during the early childhood, even with 1 or 2 episodes of UTI, there can be the scar formation that can gradually smolder as injury, and that can lead on to hypertension and so on. But I'm not envisaging, I'm not thinking in terms of reflux nephropathy in her. So most likely it seems to be some form of a glomerulopathy with a rapid deterioration. Okay. In general, compared to male and female, in whom the glomerulopathy worsens faster, progresses faster, and why?
Females, sir.
No, males, in males actually. Okay, in females, most of the diseases. Of course, you can't generalize, but now we know there are so many determinants. In general, the progression of the glomerular disease and CKD, even CKD as a whole, progression among women is subtle. I mean, compared to males, it is slower. There are many factors that are studied upon, probably hormonal influence like estrogen and so on. Okay, that's there. Fine. The thing is that the two things which we should not miss out in such a person is that necessarily you have to rule out SLE, even though she was 40. Why? Post-transplant, what is the problem if it was SLE?
Post-transplant,
if there is associated secondary APLA, if there is associated secondary APLA, yeah, there is a problem, right?
Thrombosis.
So that should not be missed out. That should not be missed out. Number one. Number two, the TMA should not be missed out because several forms of TMA, very high chance for recurrence post-transplant. So the genetic workup has to be done, and then appropriate counseling should have been given. So these are the two diseases which you should remember whenever in such a lady with severe hypertension with unknown etiology presenting to us. Fine. So can you just quickly run through the positive clinical findings in her, and then we'll discuss further.
Yes. So now the BP is normal, so 120/80. And there were no any features of stereotoxicity. Fundus was normal. Graft site also was normal, so there was no tenderness. Scar was normal. Abdomen was normal. So urine examination, protein, glucose, and blood was this was the pre-operative investigations. Should I go
No,
through some
no,
investigations?
I don't want investigations. Clinical examination, I said. Clinical examination findings.
That's also.
Clinical examination findings.
That's also.
So there is no disparity in the blood pressure.
No, sir. There's no disparity, and all peripheral pulses were felt, sir.
Felt. All peripheral pulses were felt, and then what are they? I mean, yeah. In the examination, what else you saw? Acne. There's no acne.
Yes, sir. So, there's no acne, no hirsutism, no cataract, no striae, no buffalo arm. Oral cavity is normal. There's no evidence of any fungal infections. Gait is normal. There's no lymphadenopathy. All peripheral pulses were felt.
Okay, fine. Fine. Then the system examination.
Abdomen was soft, sir. Graft site was soft. It was non-tender.
What is the current blood pressure? What is the blood pressure when you saw her?
Yeah,
what is the blood pressure?
120/80. It's 120/80, sir.
Okay. Okay, fine. Okay, fine. Fine. Let us discuss further. So, what is how many siblings? You said no family history of kidney disease, but you didn't elaborate how many siblings.
Yes, sir. She has a sister, sir. She has a younger sister.
Okay. Younger sister. Okay, she's fine.
She is
Okay.
on
So what are the
35
implications
years.
of what are the implications of the husband being the donor, husband being the kidney donor for the wife?
Sir, there's a chance of sensitization, sir, because one is through pregnancy, sir. And the HY chromosomes.
So there are two things that are striking whenever the husband is the donor. One is the positive note, because in India, the published Indian literature says that most of the living donors are women in India. Most of the recipients are men. Okay. If you look into the data of the major centers, more than 70 to 75% of the kidney donors are women. And particularly in the SWAP kidney transplant program, 78% of the donors are women. So it's a kind of the gender disparity. So it's kind of a very heartening to come across a husband being the donor. Actually, husband to wife is the least combination, the living donation that is happening. That is number one. Number two, there are published studies which have compared the graft outcome, the long-term graft survival in different cohorts. One is the husband to wife combination. Okay. And the lady, the woman with a non-husband living donor, and women with a diseased kidney donor. Okay, one is a diseased donor and the non-husband living donor, and the husband. And the husband donor, and they have procured children. They have children common. Okay, in that situation. You'll be surprised to learn that the long-term graft survival was inferior in the husband to the wife cohort. There's a paper, I don't remember, it was from Switzerland. Yeah, from Switzerland, published in Frontiers in Medicine. It's a nice paper. So how do you explain this? Why is it so?
So
as
there
I
is
already said, yeah, with pregnancy, with the more number of pregnancies, again, the chances for getting sensitization increases with the number of pregnancies. If you compare with one pregnancy versus 5 pregnancies, the chances of sensitization is higher. Okay. How to go about? Does it preclude transplantation? No, not at all. But only thing we have to be aware of this fact. Again, it's a tricky issue. Suppose in this woman, as a pre-transplant worker, if you look for presence of DSA, donor-specific antibody, if it is there, you will definitely attribute childbirth, pregnancy, as the cause for DSA. Suppose if there is no DSA, there is no detectable DSA, is it okay? Are you absolutely safe immunologically in this scenario?
There could be a non-HLA DSA, sir.
No, I'm not talking about no, for instance, imagine there is no DSA at all. When by the time of the pre-transplant evaluation, there is no DSA at all. Still, there are chances for rejections and development of DSAs later on is there. How? Because sensitization does not always, there is memory B cells. That's what I was mentioning in my, that's what I was talking about memory B cells in my presentation. The importance of memory B cells. The B cells, when they get exposed to the antigens, they get activated. And some of these memory B cells, they remain in the germinal center of the follicular, the lymphoid organs. And then when they get challenged with the same antigen later on, they can develop DSAs. So the important point to note is that in such a pair, even during pre-transplant evaluation, if the DSA is negative, it does not take away the risk. So we have to think about memory B cells. So that's it. So all that in that paper very nicely discussed, go through that paper. So that's it, fine. So what was you said there is, she was found to have some antibodies and
antibodies.
did she undergo any desensitization procedure?
No desensitization procedure was done, sir.
Okay.
As the cross-match was negative,
in a different center.
Proceeded. No, other center.
It was in a different center.
No, sir, same hospital, sir, Mayot, sir.
Same hospital. Suppose if you had found out a significant DSAs, how would you proceed?
Sir, I would like to do a single bead antigen, sir, to see to what HLA antigens are the antibodies present. I would like to do that, and also see the MFI levels, sir, for how much it is. If it is more, then I would like to go for desensitization procedure, sir.
So what is the protocol in your center?
So what we do is we give rituximab first, 14 days prior. Then we give plasma exchange like 3 to 5 alternate days. After plasma exchange, we give 5 grams of IVIG after each plasma exchange. And again, we repeat the DSA, sir, after this.
Right. So what are other methods of removing the DSAs?
Sir,
One is the plasmapheresis, the therapeutic plasma exchange. One, then
IVIG we can give, sir. Rituximab we can give, and bortezomib we can give, sir.
No. The other methods of apheresis. Apheresis, what are the other methods? One is the therapeutic plasma exchange.
Immunoadsorption, sir. Immunoadsorption can be done, sir.
And have you heard of double filtration plasmapheresis?
Yes, sir.
Yeah. So what is the advantage of double? What are the complications of this plasma exchange? What are we worried about?
So there can be loss of coagulation factors, coagulopathy can be there, sir. Hypocalcemia can be there. There is more exposed to infections, sir.
Because of the removal of the antimicrobial antibodies as well.
Antibodies.
So the vulnerability for infection is there, and that's right. And coagulopathy is there, and so these are the worries. And what is double filtration plasmapheresis? What is the advantage?
So we can remove the specific, if you want to, so we can remove the specific.
No, the titer is more better to go for that, and then the replacement volume is less over there.
Less, sir.
So you need not give the same the quantum of plasma or albumin there. So that minimizes the chance for allergic reactions and infections. So that is there. Yes. And when do you prefer immunoadsorption?
When the titers are more.
When the titers are very high. When the titers are very high, but the cost factor is there. And there, this removal of the coagulation factors, this business is not there. So please learn about the different forms of apheresis. That's number one. And then there are two ways of giving IVIG, right?
Yes,
one is, as you rightly said, after at the end of every, low dose and then high dose. Fine. And there are so many other methods, rituximab and other things are followed up. So what was the induction agent that was given in her?
See, it was basiliximab, sir.
Basiliximab. Okay, fine. So the immediate, the post-transplant period was smooth, right? She attained the normal serum creatinine day 4 itself and so on.
Yes.
That's fine. So what happened? When was the acute graft dysfunction? On day 10.
Yes, sir. On day 10, she had fever with a drop in urine and a raise in creatinine, sir.
Okay, what is the differential diagnosis for acute graft dysfunction that is happening on day 10?
Sir, we can divide as pre-renal, renal, and post-renal. So pre-renal can be a hypotension, hemorrhage can be there. The renal, we can think about CNI toxicity, ATN can be there, sir. And post-renal can be urinary leak. There could be lymphocele, and TMA also can be there, sir.
But in the renal, actually, the most important thing will be acute rejection.
Yes, sir.
So then you have to say about CNI toxicity, and it has to come next. So the most important thing is acute rejection. So I agree with all the pre-renal regular factors and so on. The transplant specific, the causes are acute rejection, then CNI toxicity.
CNI toxicity.
Yeah, that's it. So that's very important. What type of rejection again?
Sir, it was a combination of antibody mediated and also T-cell mediated, sir.
And that too in this background of she was told to have some antibodies, but
antibodies,
right?
Yes, sir.
So there is highlight. How do you explain fever?
Sir, any inflammation will present as fever, sir.
Yeah. In acute rejection, there can be fever. So fever doesn't always mean it is does not always mean infection. Acute rejection, you can have fever. Okay. Right. You mentioned about graft tenderness. Does it happen in acute rejection?
Yes, sir. Graft tenderness
it can happen. It can happen because there is cellular infiltration, particularly cell-mediated rejection. The graft enlarges. There is something called globularity index that increases. It used to be one of the methods, very primitive ways of predicting or identifying rejection those days. the ultrasound, the globularity index, and so on. And there is infiltration, tremendous infiltration of the activated cells, and the cell volume, the graft volume increases, and that results in tenderness. Again, that does not mean it is infection. There, even rejection you can have, the graft tenderness and graft enlargement, and fever as well. Okay, fine. So what was the trough level? So in that situation, how do you proceed? What is the algorithmic management of the acute graft dysfunction? On day 10, the creatinine has gone up. What is the step 1, step 2, step 3? What do you do?
Yes, sir. First, we have to see about the hydration of the patient, sir. Hydration,
Yeah.
if it's good, we
Yes.
can try giving try giving diuretics. If the patient is still not having output, we can try to see if there's any block in the urinary passages, like any block in the Foley's catheter. After that, we have to do an ultrasound with Dopplers to see the perfusion of the kidneys, to see the artery and the venous perfusion. And if everything is normal, then we have to see the tacrolimus levels. And finally, the
So what
tacrolimus
was the
level is
trough level
also
in
good.
her? What was the trough level in her?
So it was 8, sir.
Okay, fine. Then
So if that's also okay, then they have to go for a biopsy, sir, renal biopsy and see, sir.
and of course, you was looking for, you have
For
to look for any
infection.
systemic infection. And
Yes,
all.
systemic
If
infections.
there is profound evidence for infection, you have to try to identify the microbe and treat, and you can wait for other things to go. Okay,
Yes.
when there is no obvious evidence for infection, best thing will be earlier kidney biopsy. Okay, so what was the kidney biopsy report in her? Graft biopsy report in her?
Yes, sir. She had a G2, PTC3, I1 with the DSA positive and C4d positive, and the C4d was 3+ positive, sir.
And what is the light microscopic picture?
Sir, so have the slides. Shall I show the slides, sir?
I think you can describe. We may not have time.
Yes,
If
sir.
time,
Yes,
if
sir.
time permits, later on we'll discuss at the end
Yes,
of
sir.
the.
She had
presentation.
as agglomeratus where there's an endothelial swelling where there were infiltration of mononuclear cells in the endothelium. So the capillary, and there was PTC. There were infiltration of lymphocytes in the peritubular capillaries were there, and also in the artery there was infiltration of mononuclear cells in the arteries, in the media intima, with also lumen loss were there, sir. And also there is interstitial inflammatory cells also were there, sir. Tubulitis was not there, sir. And C4d was positive, 3+ positive in the medulla and in the cortex.
Fine. So what are the other forms of light microscopic presentation in the ABMR? Is this is a classical presentation?
Yes, sir.
Other atypical light microscopic presentations?
There can be TMA and also ATN, sir.
Yeah, it can be TMA. TMA is a rare form of the phenotype of the. So one of the differential diagnosis, the etiologies for post-transplant TMA is ABMR.
ABMR.
Okay, that's it. And then a simple ATN-like. And if ATN-like picture, when there is no obvious cause for ATN, and always you have to do immunofluorescence, there will be C4d positivity. Okay.
Yes.
So please let me know what is the importance of C4d and why so much of importance given for C4d. What does it mean?
So
Presence of
C4d is
C4d, what does it imply?
So C4d is a telltale of a complement activation. So it means there was a complement activation happening on the endothelium, sir.
Which pathway?
And,
Which pathway?
So it is the classical pathway, sir.
Which other pathway also we can have C4d positivity?
Alternate pathways.
Lectin. Alternate pathway start from C3, right?
C3.
So lectin pathway. But here it is only a classical pathway. Yeah, it is only classical pathway. Okay. Plus, please let me know if it is classical pathway, why don't we look for C1q or other components of complement downstream, and why on C4d specifically?
So C4d is covalently bound to the endothelium,
Yeah,
so
because
it is not
degraded.
Yeah,
it stays for a long time.
The
covalent binding, very strong binding. So it is an evidence for that. Okay. So just how I discussed in the initial presentation, the probable ABMR, that is C4d negative. There is glomerulitis, peritubular capillaritis, everything is there. Endothelial swelling is there. DSA is positive, but C4d negative. How do you explain this?
So it's not a complement binding action which happens.
So before that, we have to find out one thing. The tissue is too small. You have to think twice. Sometimes very focal distribution of C4d can be there. If there is no adequate tissue, sometimes it may be missed out. That is number one. And then number two, as I've already said, complement independent mechanism of DSA causing injury. One is some DSAs can directly injure the endothelial cells through VEGF and other receptors and so on. But the other one is that antibody dependent cell mediated cytotoxicity. So without complement, that also can happen. So that's it. Okay. You mentioned about DSA. What is the method by which a DSA was done?
It was a screening DSA, sir.
No, what is the methodology of DSA detection?
Luminex. It is a Luminex based,
Okay.
sir.
Luminex. So what are the methods of assessment of DSA? What are the various methods?
So we can do a flow cyto. We can do a single bead antigen, sir. And we can do a screening DSA with the Luminex. We can also do a flow cytometry, sir. And also CDC is also present. The CDC way of doing DSA is also
That is a primitive initial one.
Yes, sir.
The recent one is the next generation sequencing. Okay. Fine. So there are methods and it's a lot of evolution on that. So can you say something about DSA? I mean, when do you consider DSA is significant and what are the types and how do you go about, how do you interpret clinically and how do you apply that DSA result in your clinical practice?
Sir, first we have to, first what we do is we do a screening DSA, sir. If it comes positive, then we go and do a single bead antigen to find the specific antibodies what it is against, sir. And depending on the titers, we depend on the desensitization procedure, sir.
So
coming to
the
coming to the type of DSAs, we have a DSA and a de novo DSA, sir. So DSAs will, the primary DSA will be there, the de novo DSA will come after mostly like 6 months after transplant, so they start appearing after 6 months after transplant. And so DSAs, they mostly
this is a preformed and the preformed and de novo you are talking about.
Preformed and de novo.
Yeah, preformed.
Yes, sir. Preformed will be usually.
Yeah. So it's a class 1 or class 2?
Yes, sir. Preformed is a class 1, sir. Then de
no,
novo
in this
will
patient actually,
okay,
now it is a post-transplant, right? It's a post-transplant. Yes. It is a, yeah. Okay. So which one causes acute rejection, acute antibody mediated rejection?
Class 1, sir.
Usually it is class 1, right?
Yes, class 1 causes acute rejection.
And IgG subtype, which causes acute injury?
IgG1 and IgG3, sir.
Which IgG subtype, isotype, which IgG isotype? Yeah, so they are, because they are complement fixing.
Yes, complement
so they are complement fixing. So they cause, they are involved. Yeah, usually class 2 against class 2 antigens, you get IgG4. And IgG4 is not complement fixing. So that may not cause acute injury, but it is not benign. What is the problem with IgG4, which is not complement fixing and it is not causing acute graft dysfunction, but it can mediate the chronic injury, the chronic ABMR. Yeah, that's what we believe, that the non-complement fixing IgG4 mediates the chronic ABMR. Okay, it is usually the class 2. Okay, fine. So ABMR, the treatment principles, how did you treat her, Sally?
Sir, first we started with steroids. So pulse steroids was given, so for 3 days. It was 5 mg per kg per day. And then we took her for plasma exchange. We gave 5 plasma exchange alternative days, followed by 5 grams of IVIG, sir. This is the treatment we did. And also, once we got the biopsy report, we gave her 3 doses of ATG.
Right. Oh, fine. So suppose, so what are the other options? What are the other therapeutic options for ABMR beyond IV, IG and plasmapheresis? And why do you give IV, IG in ABMR?
Sir, it will remove the FC. It will bind the FC receptors, sir. It will remove, so there won't be any binding of the immunoglobulins to the FC receptors, sir. And it will also cause apoptosis of the B cells, and it also decreases the production of B and T cells, sir.
Yeah, it causes inhibition of the activated B cells. And also another important action, it can act as a scavenger of the activated complement. So the complement is mediating injury, right? You know, it can act as a scavenger of the activated complement. Actually, IVIG mechanism of action, it's very, very perplexing and multiple ways. You know, it acts very different, multiple ways. That's how it acts. Okay, what are the other options? Suppose if this combination is not working, what else you do? What are other agents that have been tried? Of course, there is no solid evidence for any of these things.
We can ask. We can try bortezomib, sir.
Bortezomib, yes.
Yes, bortezomib, sir.
Bortezomib and then rituximab.
Rituximab also.
So I mean, there are measures which, measures to attack the B lymphocytes, measures to handle the plasma cells. Yeah, rituximab, and then bortezomib.
Iclusumab, sir. Recently.
Bortezomib, yeah.
It's bortezomib and also iclusumab, sir.
Eculizumab, yeah. So, but there is no strong evidence for, there's no strong evidence for any of these things. Yeah, and anything new? Recently, some trials are going on with relevant.
So, sir is just joining in. He was asking you any recent drugs for ABMR. Some people are typing the chat box.
Yes.
There was the NGM trial this year. Come again.
Imlifidase.
Anything else?
Imlifidase.
So, what is this felzartamab?
Sorry, sir.
Felzartamab. It was published in NEGM last year. It's, I think, anti-CD38, I think. Anti-CD38 antibody. It has got a role in ABMR, a new drug.
Yes.
Can anyone say what is felzartamab? What type of drug is it? You can just type in the chat box, anyone? Yeah, it is anti-CD38. Absolutely correct. And what is imlifidase? What type of drug is that?
So it decreases the IgG, sir, from FAB and FC segment.
Absolutely. So he's just joining in. We'll just wait for a minute. Yeah, imlifidase is derived from Streptococcus originis. Correct. So you give the patient ATG and you say he had got ABMR.
So, but after the biopsy report, there are features of PCMR also, sir. And yes, that's right, sir.
Yeah, so let's join it. Yes, sir. So welcome back, sir.
Am I audible now?
Yes, sir, you're audible, sir.
Yes, sir.
Fine. Okay, sorry for that, and I got disconnected. Fine. So we were just discussing about the management protocols of ABMR. See, actually, if you refer the literature, am I audible?
Yes, sir.
Yes, sir.
Yeah. There is hardly any treatment that has been approved. So there are only two the two modes of treatment, namely the plasmapheresis, IVIG, and that also evidence is 1C and all that, 1C and so on. Even the consensus statement of 2017. In most of the patients, it works. But many of them, the response is not complete. So actually, the treatment of ABMR is a hot topic and hot research that's happening. There are many trials are going on, and different agents. As she has nicely said, the other agents that are tried, the available rituximab trials are not RCTs. There are only couple or 2 or 3 RCTs. They are not. They have not really vouched the utility of rituximab. And now there are trials employing the obinutuzumab. It's supposed to be more potent CD20 that's happening. And then addressing the plasma cells. These plasma cells, there are some plasma cells called the long half-life, the long preserved plasma cells, which they reside very deep in the bone marrow. They keep on producing antibodies even without the need for getting into contact with the antigen again. So those cells have to be tackled. So for that only bortezomib is tried. So what is the newer version with bortezomib with the same anti-proteasome inhibitor? The bortezomib problem is one is infection risk, the other one is neurotoxicity, right?
Neurotoxicity, sir.
Yeah. Now carfilzomib, carfilzomib is another drug. There are carfilzomib that's happening. It is the toxicity and it is more permanent proteasome inhibition. Okay, this bortezomib, it is a temporary proteasome inhibition. So that is being tried. And as I've already said, there are newer trials with IL-6, targeting IL-6. IL-6 has got a lot of relevance to the ABMR, both active and predominantly chronic forms of injury. And there are some trials which try to use IL-6 based agents in handling the ABMR. Can you name the IL-6 antagonists, IL-6 agents? Which drug is used? The one which we use for COVID, the tocilizumab. There is one trial going on whether it is useful in the active form itself, but predominantly IL-6 based agents, both tocilizumab and one more drug that is published in Kidney International some time ago, clazakizumab. Okay, clazakizumab is nothing but a humanized monoclonal antibody against IL-6. There is one trial, a named trial is going on. It's called Imagine trial. Phase 3 trial is going on. So that will throw, we expect that will throw more light whether IL-6 blockade helps in chronic ABMR. So if this active form, if it is uncorrected and the DSAs don't disappear, and what happens is that over a period of time, the injury is lingering on. Then it becomes a subacute form of injury and then the chronic form of injury. Now, the chronic active ABMR, that's the current terminology that also is being there in the newer bands, right? In such situations, we don't know really whether to give aggressive immunosuppression or not. So that is it. So there is one more trial called Intercept trial that is using tocilizumab. Okay, that also is ongoing. So one is Imagine, the other one is Intercept. Imagine is using clazakizumab, Intercept tocilizumab. Okay. Suppose if, and again I have already said, the daratumumab plus belatacept, that combination. They prefer particularly those who are sensitized, in whom the ABMR risk is high. So there are trials, named trials are going on with that. Why daratumumab is that, it also handles this memory B cells. So there is so much of, in the current literature, there is so much of importance for the memory B cells. And particularly the memory B cells, which evolve because of sensitization during pregnancy. They are very resistant to any form of therapy. Again, sensitization due to various causes, like the transfusion or previous transplant and pregnancy. They say pregnancy associated, the sensitization is a bit more resistant to forms of therapy and so on. Okay. How do you handle? Suppose the ABMR has happened after 3 months of transplant. So this 3 months cutoff is based on the consensus statement. So what is the importance of that? Why this 3 months cutoff?
3 months. It's time taken for the memory B cells to increase in number, or it can be because of the de novo antibodies also, sir.
Exactly. So by and large, any preformed DSAs, they inflict ABMR less than 3 months itself. So if it is beyond 3 months, it's more likely, not always, more likely to be the de novo. Okay. So of course, ABMR is happening much later. Do you still give plasmapheresis and IVIG? What is the current consensus statement?
So in the later, we would try to give IVIG. So plasmapheresis has no major role in the chronic ABMR.
Exactly. So that's it. So that is the in the therapeutic implication, why this the timing of occurrence of ABMR. So the preformed DSAs, they cause ABMR less than 3 months. Okay. So what is the histopathological pattern of chronic ABMR?
Sir, they'll have tubular granulopathy, and they will have multilayering of the PTC, and they also can have arterial hyalinosis. Sir.
What is transplant glomerulopathy?
So transplant glomerulopathy there'll be doubling of the glomerular basement membrane, sir. There'll be an additional layer of the glomerular basement membrane formed, sir, because of the repeated injury and also reformations.
Yeah, double contouring of the glomerular basement membrane, and then multilayering of the
PTC.
PTC. So these are the two important things. And actually, initially, transplant glomerulopathy was thought to be due to many etiologies, including even hepatitis C was implicated about 1.5 decades ago. But now it is, we are fairly convinced that the morphological pattern of transplant glomerulopathy in the graft biopsy is almost always due to chronic ABMR. Okay. And also you have to remember, the chronic ABMR is the most common cause for IFTA. After some time, if your biopsy is much later, you may not have the telltale evidence of the glomerular pattern of injury of chronic ABMR, but you may simply come across a severe IFTA. Okay, tubular atrophy and interstitial fibrosis. In the past, we were thinking more in terms of cyclosporin toxicity as the more important cause for IFTA, but now the most common cause for IFTA is chronic ABMR. Okay, fine. So, what is the current status? What is the current serum creatinine?
So now she has a creatinine of 0.8, sir. She's having a stable creatinine value, sir.
She's very fortunate. And can you just explain? Now we'll discuss on the infectious episode which she suffered.
Sir, after 6 months of transplant, she had an episode of UTI, sir, which was likely to be an upper UTI, sir, upper urinary tract infection, where she had to take IV antibiotics and continue antibiotics for 14 days, sir. During that time, the USG abdomen and the transplant kidney bladder, everything was normal, sir.
So, what are the predisposing factors? What are the initiating factors for UTI?
So, female gender immunosuppressant is a transplant patient, and other risk factors are like diabetes mellitus.
So, in her, she is not a diabetic, right? She has not developed PTD.
No, sir. Right? No, sir. She is not diabetic, sir. So,
mainly it's only altered anatomy and immunosuppression.
Yes, sir. Yes.
So, is there any risk factor in the early stage UTI, post-transplant UTI occurring early?
In this patient, sir? In this patient,
in general transplant recipients.
Yes, sir. Yes, sir. Because of Foley's
the prolonged
catheter.
retention of the urinary catheter. So
Yes,
the
yes.
day of removal of the catheter is very important. There are some centers, due to some or other reason, if the Foley's catheter, if it is retained for a longer period, every day counts actually. The longer the duration of the catheter being in place, the chances for UTI is higher. And that too, UTI that is happening in the hospital setting, sometimes, there can be MDR, but it's very difficult to treat. What are the implications of UTI in a transplant recipient?
Implications of UTI. Sir, infection can trigger rejection, sir.
Yeah, exactly.
That is one.
Yeah, beyond the routine complications of UTI, here the problem is that it can predispose for the rejection episode, and the graft survival itself can be hampered if there is a recurrent UTI and so on. So it is not always immunological challenge for the rejection to happen. Thing is that the pro-inflammatory cytokines, they can stimulate the already sensitized quiescent remaining immune cells, and that can result in the rejection episode, and there can be enhanced expression of the HLA molecules as well. So any infection acts as a trigger for rejection. That's true for UTA as well. And so the duration of treatment, antibiotic treatment in graft pyelonephritis is
for 14 days.
14 days.
14
and also days. In post-transplant UTI, it is not always bacterial. You have to remember the other microbes causing UTI as well. What are the viruses that cause UTI post-transplant?
So BK virus, adenovirus.
Adenovirus. So which one causes the hemorrhagic cystitis caused by both?
Is a both.
Which fungi cause urinary tract infection?
So Candida.
Can there be fungal UTI? Yeah.
So Candida UTI can happen. So
you have to be all the more careful. So, Candida. And whenever there is a prolonged antibiotic therapy, actually, you have to remember emergence of fungus as well, and particularly uncontrolled diabetes and so on. A fungal UTI can be a real problematic thing that can quickly degenerate into a kind of a system. So it has to be a very aggressively treated. That's it. And undiagnosed voiding dysfunction, because in some people, when they present to you with very advanced stages of CKD, and by the time they present to our system unit with low urine output, you may miss out voiding dysfunction in them. Post-transplant, when the urine output is really improved well, that time it may come to surface for the first time. Okay, some neurogenic component, and that can be a predisposing factor for UTI, like retention, voiding dysfunction. Particularly, it happens people with diabetes. That can be autonomic neuropathy, residual urine, all that. So that can be completely missed out during the pre-transplant period because of the very low urine output. And how do you handle immunosuppression when there is a graft pyelonephritis? Will you continue the same immunosuppression, or will it come down?
So the antimetabolites mainly should be reduced or stopped, sir. So mainly myfortic or azathioprine should be stopped or reduced, sir.
Fine. It all depends on the severity, and it's not a single line answer. Like every day, the patient has to be assessed, and the balance between infection and the rejection risk has to be assessed, and then we have to walk on the midway. So that's a very tricky issue, because it's not just infection being the trigger for rejection also is there. So it has to be very carefully handled. And based on the graft function, the antimicrobial dosage, some of them may require modification as well. The dose modification as well, that also has to be borne in mind. Okay. So what are the organism in the urine culture in her?
So it was E. coli.
E. coli. Okay. So now she had one episode of ABMR, and there was some suggestion for sensitization. So how will you monitor her here afterwards? Or you just will be really complacent with normal serum creatinine of 0.8. Is it okay? And you will do something else.
Sir, we have to repeat a DSA after a year, sir. And we have to monitor DSA levels, sir. Mostly every year we have to monitor DSA levels.
Actually, there's no fixed protocol like that. There is something called immune surveillance. Immune surveillance. Each unit has got their own way. So she's definitely a candidate for an immune surveillance because that vulnerability is always there. Do you advocate protocol kidney biopsies in such patients to pick up early ABMR, very early stage?
We can advise.
No, again, opinion is divided. Many a times, there is discordance between the clinical picture and the microvascularity. If you pick up some peritubular capillaritis, and you'll be perplexed as to how to go about. So there are pros and cons for this protocol biopsies, and most of the centers they have just given up and all that. There are certain positives, like if you pick up very early, you will not down titrate the immunosuppression as we do over a period of time. In such a person where there is evidence for subtle microvascular injury itself, you will try to maintain a very stiff maintenance immunosuppression. That way it might help. So that's it. Okay. What are the non-invasive methods of diagnosis of ABMR? Anything?
Do a cell-free DNA can be done, sir.
Yeah, donor-derived cell-free DNA.
Yes.
So when it was introduced, it was a big hype, and we thought, that is going to be a real help and so on. But now we understand the flip side of it and the caveats of it. What is that? It is very non-specific, right? Very non-specific. So the abnormal result can be due to any form of graft injury. Only thing, it gives a very high negative predictive value. Only that way it helps. Okay. So it's very non-specific. It is not just only denoting, but still it is in certain selected situations. It may really help you, particularly a negative predictive value it offers. Okay. Fine. So what is the current maintenance immunosuppression in her?
So she's getting prednisolone 5 milligram, taxane she's getting 1 and 0.5, and myfortic 360 morning BD, sir.
Oh. Right. So what are the non-immunological problems you encounter in post-transplant patients? How do you monitor them?
Sir, we can have a post-transplant diabetes mellitus, sir. They can have hypertension.
Very good.
They can also have dyslipidemia.
Yes.
Then they can have steatotoxicity can be there.
Bone disease. Very important.
Bone disease can be there. Yes, bone disease can be there, sir. They can have post-transplant erythrocytosis can be there. So polycythemia can be there, sir.
Right.
And also they can have steatotoxicity can be there, and CNA toxicities can be there, sir.
So the infectious complications and then metabolic complications.
Yes,
okay, they stand at a, please remember, they stand at they are at high CV risk patients. They are.
Yes, cardiovascular risk also.
High CV risk. Okay. Fine. So what is the current tacrolimus trough level in her?
Current seems.
Okay, so what will be the range? 6 months post-transplant?
Yes, sir. So we try to maintain between 3 to 5, sir. After 1 year post-transplant, 3 to 5 we try to maintain, sir.
3?
So 3 to 5. 3 to 5.
5. So how do you explain her severe hypertension warranting many drugs pre-transplant? Now how many antihypertensives she's on?
She's on no antihypertensive now, sir.
How do you explain this? Are you not surprised? Of course, we do come across. We have published a paper on, from MMC, we have published a paper on post-transplant hypertension in Indian Journal of Organ Transplant, IJT. There we have classified as, those who had hypertension continue to have hypertension, then those who didn't have hypertension pre-transplant developed hypertension post-transplant, and those who had hypertension but subsequently developed became normotensive. That portion is very small, because like already there was such a severe hypertension, and post-transplant, patient is on steroids and CNI, so many factors. How do you explain this normalization, so-called normalization of BP in her?
So the pre-transplant BP could have been because of a volume overload state, so which is not now.
Correct. Good. How does CNI cause hypertension?
Sir, CNI causes afferent arteriolar vasoconstriction, sir. This leads to RAS activation, sir. That is one method, and also it causes arterial hyalinization also, sir.
Even otherwise, endothelium release causes endothelium release, and that can cause vasoconstriction.
Endothelial release. It
Which
decreases
is
the nitric oxide
antihypertensive
release.
of choice for CNA associated hypertension. No. The calcium channel blocker.
Yes, sir.
Transplant hypertension. Fine. Can you use RAS inhibitors in post-transplant hypertension?
So inhibitors can be used, sir.
So the thing is that you have to be extremely careful. Because it's almost like a single kidney status, and there can be the subclinical transplant renal artery stenosis. It may not be very overt. So if in that situation, if you give RAS inhibition, that may be problematic. So we have to reserve for only some patients. But once the graft dysfunction happens, carefully help it start. But not when the graft function is absolutely all right and so on. Okay. So how about statin use post-transplant?
Statin used, yes, when if the patient is having dyslipidemia, so we can use statin. So
which statin you prefer and why?
I have to see, sir.
What is less call study?
Yes. As a less call study, they have used
fluvastatin, no?
Yes, sir. Yes, sir.
It's only a mild dyslipidemia, you go for fluvastatin, but it is a little significant dyslipidemia, you have to go for rosuvastatin. Okay, because the drug interaction, because the same cytochrome protein and also on. So prefer rosuvastatin. Okay. So why I'm asking all these things is that like the transplant nephrologists always will be immunology centric follow up, and sometimes we tend to ignore these things. Always we have to remember these people are potential CV morbidity and mortality patients. So a lot of CV risk factors are there: the hypertension, diabetes, and over a period of time graft dysfunction that's happening, and dyslipidemia, and weight gain, excessive weight gain, all those things. So they are highly vulnerable for all. Okay. And most important thing in this patient is that the adherence to immunosuppression, because in most of the patients in transplant recipients, as I've already said, chronic ABMR is the most important cause for chronic renal graft loss and IPTA. And the most common cause for the chronic ABMR in them is the non-adherence, suboptimal immunosuppression and non-adherence. So that is a major issue. Okay. So which drug was promoted to circumvent the problem of non-adherence post-transplant maintenance, which is given under direct supervision? It has to be given only as IV infusion. Yeah, somebody has answered. Belatacept, Yeah, belatacept. It was introduced that way, it can overcome this non-adherence issue, and it can circumvent the CNA associated nephrotoxicity and so on. So, but the problem with the belatacept is, what are the problems with belatacept? The proposed dosage is that 10 milligram per kg per dose IV infusion on day 1 and day 4, day 5. Then 2 weeks, 4 weeks, 6 weeks, 2 weeks, 4 weeks, 8 weeks, and 12 weeks. That's all. This is the initial phase, 10 milligram. Then maintenance, only 5 milligram per kg once a month. So idea is that you can bring the patient, definitely you can sure that the patient is taking. But the problem, what are the two problems? Particularly those who are EBV negative. Yeah, EBV negative, the chances for lymphoproliferative disorders was pretty high. And of course, cost issues and so on. So initially there was a lot of, when it was introduced, there was a lot of enthusiasm on that, and then it couldn't pick up. So that's it. So here is a patient with ABMR, and there was evidence for some subtle sensitization before. And fortunately, her current graft function is normal, and no major infectious illness, but for one significant UTI episode, complicated UTI. All is well so far, but in future, like close immune surveillance is required, and reduction in the maintenance immunosuppression has to be done with utmost caution, taking care of infections and so on. That's it. Anything particular you would like to discuss? How about a menstrual cycle?
So she had a regular 28 days 28 cycles.
Okay. She's able to kind of perform all her day-to-day work and so on. The functional status is perfect, right?
Yes, the functional status is perfect.
Right. And then the donor has to be followed up. The donor follow-up is of utmost importance. Many times the donors are ignored. Ideally, every unit should have a donor follow-up clinic. And because now we know the safety of donors in the long term, still we need more data. In the short term, it's all fine. So the 3 parameters which we do look up. One is the proteinuria and the blood pressure and the serum creatinine. And it has to be, these things have to be checked periodically. And there are some reports, particularly from Norway and so on. 20 plus years follow-up, the results are not okay. The observations are not really encouraging. There is slightly higher incidence of CKD in them and so on. So what happens is that, these donors, like our AKI survivors, they have to be subjected for scrutiny periodically, and if there is some subtle abnormality like even proteinuria, very aggressively it has to be addressed. All renoprotective agents have to be employed, and the lifestyle modifications and taking care of the weight and avoidance of necrotoxic, all that periodically it has to be done. The to husband who has donated to wife, he has to be really adored and appreciated. Fine.
Thank you, sir.
Thank you.
It was a very
nice
interesting.
presentation.
Yes, sir. So we have 2-3 questions. Due to the paucity of time, we'll take only 2-3 questions. One question was like, what rejection do we expect in the early post-transplant period? So do we expect to see more of TCMR or ABMR?
Pardon me, say it again. Post-transplant?
So in the early post-transplant period, what rejections do we expect, like TCMR or ABMR in the early period?
Yeah, in the early period, most common is the T-cell mediated rejection. But T-cell mediated rejection happens only after 5 to 7 days. Now, because like the antigen presentation and the IL-2 generation and proliferation of the lymphocytes and then recruitment of the cells into the graft parenchyma, that takes minimum 5 to 7 days. So very early, before 5 days, the T-cell mediated rejection is little rare, and there are some explanations for that. So whereas ABMR can happen in blood, particularly if there is a preformed antibodies which are missed out, that can happen early. And even without demonstrable DSA pre-transplant, As I've already said, but the presence of the memory B cells, they can quickly get activated, and in no time they can form antibodies. So ABMR can happen much earlier.
Sir, another question was, if you see ATI on allograft biopsy and it is C4d negative, so do we need to do DSA in all these cases? Like CNI
No, I
toxicity
don't
is
think.
another. Yeah.
No, I don't think so. Like, acute tubular injury, in the context of C4d positivity, then only we can strongly think in terms of ABMR. So when there is C4d negative and there is acute tubular injury, I would like to think in terms of other causes for ATI, like CNI, other drugs. There are many drugs which we give, even antibiotic prophylaxis and antimicrobial. There are empty number of other causes we can cause it. ATI with C4d, we think strongly in terms of it.
Dr. Archana, probably you can take this question, like how do we differentiate between glomerular versus the interstitial pathology of CKD based on your history itself? This is a favorite exam question, I guess.
Yeah, I would like to rule out the CTID because patient had hypertension, so there were no any particular reason for any CTID with hypertension in these patients, any causes like that. So that's why I fixed to a CGN. And she did not have any. She did not have any complaints like easy predictability, like any features of anemia wasn't there. She was not having nocturia. So these are the reasons why I did not go for the CTI. CIN.
In general, when do you think in terms of tubular interstitial pathology, is that one is the non-oliguric form, absence of edema, then disproportionate anemia, disproportionate acidosis, and very early onset of CKD MBD, the bone disease, and disproportionate hyperuricemia. In all these things, like you think more in terms of tubular interstitial pathology than glomerular pathology, because all these things, the tubular functions, acid handling, uric acid handling, and erythropoietin comes from the interstitial cells, that's why. But it's all, it's all yesteryear questions, and there is a lot, now we know there are a lot of overlap here and there and so on. As I've already said, we have come across any number of patients with pure IgA nephropathy, patient remaining non-oliguric. So it all depends on, it's like even in a primary glomerular disease, always there is a secondary tubular and interstitial pathology, right? Pure pathology limited only to glomerulus, we don't come across. Like over a period of time, there is the progressive tubular and interstitial injury. It's all the degree of the tubular injury that decides the urine output. So, but still, if exam somebody asks, this is that.
So someone has asked like causes of transplant glomerulopathy apart from chronic ABMR, like TMA can also lead to transplant glomerulopathy without other changes of TMA or not? Like what are the main causes of transplant glomerulopathy if you see that on biopsy?
Yeah, so it is a nice question. The chronic TMA of the NP cause, even in the non-transplant setting, chronic TMA, it assumes MPGN pattern later on. In the acute phase, the classical TMA picture, endothelial swelling and downstream ischemic change in the glomerulus, it's all acute. In the TMA, later on, it gives way into it evolves into a kind of an MPGN pattern, the double contouring and then accentuated lobularity and so on. So MPGN pattern in the light microscopy, but immunofluorescence, there is no immunoglobulins or no complement. So the top cause is your TMA, chronic TMA. But here, this transplant glomerulopathy is very specific pathology. It's not just the double contouring of the glomerular basement membrane. In addition to that, there will be mesangial expansion, and sometimes there is the occlusion of the arteriole. In addition to that, you can have this multi-layering of the peritubular capillary cells. So that is very classical pathology. In the past, without knowing about the chronic ABMR, people thought, it is a very peculiar pathology that can be due to many factors, many diseases, including viral infections like hepatitis C and all. That's what it thought of. I think it's now it's very clear it is only chronic ABMR. I don't know whether other factors will be contributing for this pathology, but transplant glomerulopathy is classically is the graft phenotype of the chronic ABMR.
So we can take one last question, which will be, what is the significance of microvascular inflammation on the biopsy with C4d and DSA negative? So do we treat it similarly on the lines of ABMR, or do we do something different?
That's what is I was trying to project in my initial presentation. This is microvascular MVI. Not all MVI is due to DSA mediated. That is the current concept. So when there is MVI, microvascular injury, which is not due to DSA, in that situation, there is no place for plasmapheresis, not at all. It is believed to be due to NK cell mediated. So currently, none of the immunosuppressants have a real say on NK cells. But as I already mentioned, the newer agents like daratumumab and so on. So a lot more research is required in such pathologies. I'm sure every center will come across C4d negative and DSA negative ABMR like histopathological phenotype. There is microvascular injury. How do we discuss this actually? C4d negative because of this non-complement mediated antibody injury. And DSA we are not able to pick up because it may be due to non-HLA DSA. So for argument's sake, it is fine. But we do encounter this kind of MVI without C4D, without DSA, very often nowadays, almost every center. So the same hypothetical explanation does not hold true for all situations. Now the current knowledge is this. It may be due to other mediators of injury. In such situations, better don't go for this thing like plasmapheresis and IBM and so on. But thing is that when you come across this thing in a disease donor transplant, you can't really do DSA, right? So whereas in a living related donor transplant, if you are able to do DSA and that is negative, and C4D also is negative, you think differently.
Thank you, sir. This was a very insightful session, and we learned a lot of new things in transplant. We would also like to thank all of the attendees for staying up till this late. Thank you all. You can join our WhatsApp group for more updates. The link is mentioned in the chat box below. Thank you, Gopalakrishnan sir, and thank you, Dr. Vineet, and thank you all. So we'll wind up for today. Thank you.
And finally, one homework for all the attendees. Go and learn about combat trial, COMBAT, combat trial. Okay, during our next session, we'll start discussion with that. Thank you. Good night.
Thank you.
Thank you.
Thank you,
Good night.